Good evening. I'm beginning to wish I had gone first. It's really a great honour to be here this evening at the MacGill Summer School, and I'm so honoured to have been invited to contribute to what is now a really iconic institution and very much now known as a forum for a contribution to public debate and discourse. And I want to pay tribute to Joe and all the team for this wonderful event. So thank you so much for having me here, and thank you to Donal for moderating this session. I really enjoyed the contributions and indeed learned quite a bit already from what has been said. But I don't want to start this contribution by just saying the health service is dysfunctional. I think one of the risks facing the Irish Health Service and facing us as a people in terms of how we interact with the health service is that sense of, can it ever be fixed? And accepting that we only ever talk about the Irish Health Service in the negative. When did it become the norm to only talk about our health service in the negative? Because whilst there are clearly challenges, and if we didn't know it before we came into this room, we certainly know it now after those 3 excellent presentations, there are clearly challenges. And people like Patrick clearly are being failed, as outlined by Fergal. There are clearly challenges. People have been let down. There is so much to do. But none of that's taken away, and nor do any of the speakers take away from the fact that most of the service being given in the Irish Public Health Service is being given by dedicated, highly skilled, highly motivated staff. And we have seen those staff operating in the most horrendous conditions over the last 10 years, where they've lost many colleagues, where they've seen their own wages, people who weren't always very well paid to begin with, working on the front line of our health service, they've seen their own wages decimated, and they've seen this year 7% more people so far attending our emergency departments. Now, our population hasn't increased 7% since last year. We haven't had 7% more older people in the country since last year. So there is a particular phenomenon in terms of demand and the demand that is placing on the system. And I want to begin by acknowledging that. However, the main problem, I think, and the main problem that I hear very clearly from the Irish people, is the way we subject our patients in this country to a unique kind of hazing process before we get them access to that excellent care. And I want to come back to that in a moment. But firstly, the reactions I experienced when I was lucky enough to be appointed Minister for Health, lucky enough, the reactions were a curious mix of congratulations, messages of sympathy, references to poison chalice, and a curious mixture based on the assumption that I'd be shaking in my shoes and properly fearful about entering what gets called Angola. And I want to assure you that's not the case. I'm proud and excited to be Ireland's Minister for Health, and I don't think it makes the job any easier going around grumbling and giving out how unfortunate you are to be the Minister for Health. I'm honoured to hold this post. And that doesn't suggest, or I hope it doesn't suggest to any of you, that I'm in any doubt about the massive scale of the task that we face. But I've never bought the Angola analogy, and more to the point, I don't think any of us should. This country can and does and has achieved incredible things in relation to amazing challenges when we put our mind to it. We've done it in relation to the peace process on this island. We've done it in relation to hauling our economy back from ruin on not one but several occasions. Why can't we now do it in relation to the Irish Public Health Service? Why can we not decide that collectively this is what we're going to work on, that this is going to be priority number one for government, but for all of us as citizens of this republic? Where is the gain in standing in a defensive crouch, ready to reach for excuses? Where's the gain in talking about reform, talking about tinkering at the edges, when we could be talking about vision, about direction, about setting out not just to be as good as a few other countries, but setting out to actually say, why can't we have the best health service in the world? I believe in a vision where we stop worshipping the system, the process and the problems, where we turn everything to face the patient, where we start with the rights of the citizen to a healthy life, to an equal chance at a healthy life, and to civilised care in the face of illness. That's not a problem, ladies and gentlemen. That is a massive challenge, but it is a massive positive challenge. And let's say, where do we want to be as a country if we gather in this very room in 2026 to mark, I think, the 46th MacGill Summer School on that occasion? Where do we want Susan's figures from the OECD to be then? Where do we want Ireland's health system to be? This is a huge challenge, but why must it be seen as a negative challenge? This is a positive challenge for all of us to work on. And yes, it demands energy, demands vision, demands hope, determination, but it also demands optimism. And before you go, Asher, isn't he just a young, naive lad standing at the top of the room 10 weeks into the job? God love him. Let me lay it on the line. Without great objectives, no great achievements happen. We must be realistic, of course, but we must strive for the best and nothing less. The fact is that every great advance in health, and not just healthcare, but advances in survival and also in health promotion, came out of great times of challenge. And just one example, if we go back to the Crimean War of all places, the mortality rate then was absolutely horrific amongst British soldiers, many of those British soldiers actually being Irish people. And we all kind of vaguely know that Florence Nightingale was involved. She was walking the wards of the wounded with a lantern. The lady with the lamp, she was known as. And yes, Nightingale was nice to the patients, but that's not why she's important in terms of the history of healthcare. She's important because of the advances she made. She worked out that the lads weren't actually dying of their wounds. They were dying of preventable infection in those wounds. So she drove new systems of hygiene, new systems of sanitation. She figured out that the hospitals she was running needed to be reconfigured. Yes, that meant more money from the government of the time, and she was thousands of miles away. So how was she going to explain to the powers that be what was going on at a ground level? And Nightingale worked out the visuals that make data understandable. She essentially invented the bar and the pie charts that pop up today in every second PowerPoint presentation. And they worked. So out of that tragedy, out of that huge challenge came better practice. And over time, that better practice became basic practice, became essential practice, and thankfully is now unquestioned practice. But here's the thing. Neither her advances nor any of the other breakthroughs like antibiotics bring the health service anywhere into a state of perfect balance. They don't ever create a health service that's all set, grand, fixed, perfect, done, we can move on. Every advance in healthcare creates new needs and, yes, sometimes new crises. Since 2004, life expectancy in Ireland has increased by 2.5 years. It's now above the EU average. People in this country now live longer than their European counterparts. That's clearly an advance. Between 2005 and 2014, mortality rates across a range of diseases fell. We saw mortality for circulatory system diseases fall by 31.5%, for cancer by 7.9%, for respiratory system diseases by 20%. More advances. But every single one of those advances creates a knock-on need and a new challenge. A century and a half ago, the health system didn't have to think about, never mind care for, people in their 70s, their 80s and their 90s, because these people were, quite frighteningly, outliers. Well, they're not outliers anymore in this country, thank God. We've learned to prevent many of the diseases that felled previous generations, and indeed felled them early. We've learned to cure many of the diseases that waylay us today. We have other diseases to cure that are systemic rather than patient disease, but it can be done. We've cured other systemic ailments. We can make major changes when we put our minds to it. We can modernise and we can improve the way we deliver health services when we have strong policies and determined and sustained delivery. The health service that we have in this country, let's be honest with each other, grew up as a patchwork of individual initiatives and individual institutions. Those institutions, albeit they well-minded, tended to develop themselves, often in isolation, and the services, indeed, that they provide in response to local needs. What they have never done, and still don't always do, is function fully and coherently as part of a national system. We have not yet combined in this country excellent people and excellent institutions into an excellent system. We've tried, and I suppose it's fair to say we've tried successively over many, many years in two different ways. One of the ways we've tried is by rejigging the structures. This started with the development of the health boards, then the creation of the HSE, now the focus on hospital groups. And the other way we've tried is to combine excellent people and excellent institutions through concentrating on finances, trying to ensure that the resources flow to where they're needed within the system. This second approach started long before my time with the Commission on Health Funding, which reported at the end of the 1980s. Both of these approaches, the structural and the financial, make sense, and yet neither have gotten us to where we want healthcare in Ireland to be. Now we have a new model for funding public hospital care called activity-based funding. It involves moving away from the inefficient block grant budgets to paying the hospitals. You don't just give them a lump of money and say that's your money for the year, but you actually pay them based on the volume and the quality of care that they provide for patients in this country. It's complex, It takes time, but I really believe it will be and is a powerful driver of reforming the way we deliver health services. So we're moving ahead with these reforms and changing the way the system is financed. But if you think about it, and again being honest, these are reforms that are good for the system. And we tend to assume, and this is quite worrying I think, we tend to assume that when we have a reform that's good for the health system, it will automatically be good for the patient. And I would suggest we've lost at least 1 decade, if not 2, based on presuming health system reform is automatically reform that benefits the patient. That's where I believe we really have to now create a constant national learned reflex that causes us to say, really? Every time somebody tries to convince you that a system reform is automatically a patient reform of benefit. Let's say tonight one of us, God forbid, gets a sudden onset of painful, disabling symptoms and we pitch up at the emergency department to get those symptoms addressed and a diagnosis made and treatment commenced. You know something, I seriously doubt we'll find ourselves too preoccupied thinking about activity-based funding. We've been triaged, we're sitting around crowds of people who are sick or injured in different ways. We probably feel wretched. Hours pass, perhaps we've no clue when we'll be seen. Activity-based funding, I can assure you, will be way down the list of your priorities. Elizabeth Kubler-Ross defined a series of stages people go through when they've been given a diagnosis that tells them they're going to die. They go through shock, bargaining, several other emotional reactions before they reach resignation or hopefully serenity. If we took the Kubler-Ross approach to the entry point to the most acute care, I suspect the Irish patient's first experience is often fear. The terror of having some pain or some symptom that we simply can't explain. Next comes relief. They feel, at least I'm in the hospital. Then comes worry. Why are these people being seen before me? When will I be seen? Then comes anger. Why is nobody telling me anything? And then, all too often, comes the now infamous hospital trolley. And that's bad enough, but it's when they're left there in the bright, apparent chaos of an emergency room that another feeling takes over. The feeling of being disregarded, disrespected, of not mattering, of being simply a cog in a system that is meant to serve, not just meant to process, a system that knows how to count the trolleys, but where the people lying on the trolley often feel like they themselves don't count. A system where trolleys now, and I don't know when this happened, seem to evoke acceptance instead of intolerance. We count the trolleys in this country now, and only when they reach a certain level do we read it in a newspaper, do we see it in a TV broadcast, does it be raised in the Dáil. There is an acceptance of the presence of trolleys, and that acceptance rather than that intolerance is a worrying thing that has crept into our health service. We have to move forward structurally and in our financial systems, and in 2 other areas I want to come to in a minute, but we have to build every single step of the way on the question, is this really good for the patient? And what I want to do is take all of the good work being done down through the decades, all of the passionate and committed health and social care professionals that we have in this country, all of the investments we have made and we will make, and point them not just at clinical excellence, though that's very important, but at making sure every interface with the patient is respectful, responsive and reassuring. I suggest they are the new 3 R's that this country needs to learn. Every time an Irish patient comes in contact with healthcare, whether the patient is 3 years of age or 20 years of age, it should be a positive experience. The patient should feel they matter. The patient does matter. That healthcare people want to see them quickly, want to solve their problem quickly. That patients aren't just an irritating factor gumming up an otherwise perfect, lovely system. That they're not a statistic. And that's about communications as well. But it's about every other tiny aspect of healthcare too. The patient matters, the patient comes first, and that does mean there's 2 further missing links that we need to join up in this country. Prevention and primary care. Right now, there are patients in each and every one of our hospitals suffering illness and impending death because of the failure to prevent their illness 30 years ago. The cost to them and to their families is clearly unspeakable and immeasurable. The cost to the state is massive. And that's because of one product the only commercial product that kills 1 out of every 2 of its users, the cigarette. The death march of the cigarette teaches us so much about the prevention of ill health. Tough lessons, absolutely, but positive lessons too. We now know that many of the dire illnesses, whether they cancer or heart disease, that a couple of generations ago were regarded as visitations from an evil god, could in fact have been prevented if patients had never become addicted to smoking. So we say, had we but known. Yeah, well, now we do know that if we want Irish people to live longer, healthier lives, prevention has to start early and with every individual. And this goes well beyond tobacco. Every one of us needs to be put in charge of our health from very early on, to understand that how we live now will determine how we live later, to have the data to inform our habits around food, around exercise, around stress, around sleep. Within days of becoming Minister for Health, I saw a report given to me that shows if we don't get on top of the obesity challenge in this country, not only will we become one of the fattest nations in Europe, it will cost our health system over €5 billion a year. Now, that's something in the control of each and every one of us as citizens in this country. How have we allowed it to be that 1 out of 3 children under 3 are either overweight or clinically obese in Ireland? How have we allowed this to happen? When did this become okay? When did we just accept this as a trend that is continuing, is progressing, is getting worse? And tightly linking into prevention is primary care and a new vision for primary care. And I take very seriously what Fergal says. This isn't instead of acute care. But this is about deciding what we can do in the community. We need primary care that matches or exceeds the best in the world in order to keep people from needing acute care in the first place. It must focus on keeping patients well, on actively managing patients' needs, and reducing as far as possible the number of patients that doctors in our emergency departments ever have to see because we keep them well in the first place. I think of it as better care closer to home. A primary care system which is not just about bricks and mortar, but about the services inside. And if I'm to be self-critical, I think one of the mistakes we made in the last government, and probably even the one before, was that we went around counting primary care centres. And isn't that great, we've opened another one here, and isn't that great, we've opened another one there. And it's really important, by the way, you need buildings to provide services. But what's much more important is what happens in the building. And if nothing new happens in the building than what would have happened in the GP surgery, well, then we haven't developed primary care any further. And if we are serious about developing primary care further, yes, GPs are absolutely central. And we need a whole new approach to this in terms of a new contract, in terms of looking at salaried GPs in areas of rural Ireland and parts of urban Ireland where it never makes sense to operate a business as a GP, but where there's a societal need for one. But so are nurses, so are social workers, so are pharmacists, so are dentists, physiotherapists, a range of other professionals. And this work requires coordination and integration. And that's why I'm bringing all of these groups together in September. And I'm bringing them together to have a discussion about what they see as the role of their profession, about what we, the state, need them to do. Because rather than I sitting down and negotiating a siloed contract with a GP, then a siloed contract with the dentist, then a siloed contract with the pharmacist, we've got to decide as a state who's going to do what and how are we going to make sure all of the areas we need covered locally in the community are covered. But the other point we've seen, and Fergal talked eloquently about this, is we've seen a growth in the number of people living with chronic disease, be that cancer, be that heart disease, be it diabetes. Quite a scary statistic. If you're over 50 years of age in Ireland, you have a good chance of having at least one chronic disease. That's simply a fact. If you're over 50, in fact, 1 in 10 of you will have more than one chronic disease. Chronic diseases now account for 80% of all GP visits, for 40% of all hospital admissions, and for 75% of hospital bed days. And obviously, as the number of older people increases in this country, as it's beginning to do, this burden of chronic disease will also increase. But the rising burden of chronic disease also requires us to rethink the way we provide and the way we deliver our health services. Chronic disease by its nature is ongoing, it's continuous, so too must the care models be. We need systems that are reliable, that are capable of addressing and responding to the many and sometimes complex needs of patients. And for that to work, we have to place a far greater focus on the care in the community. And I do believe we've made a good start, finally, in this country. The first 2 phases of universal GP care are in place. What does this mean? It means there's 800,000 people in this country who are now automatically covered for GP care without fees and without the need for a means test. But it means more than that. It means that 20,000 children under the age of 6 have now been signed up for a new cycle of asthma care. More than 62,000 adults, as a result of this, with type 2 diabetes, have now been registered by their GPs for a new programme that sets out to manage it better and to keep them healthier. Did we go about introducing this in the right way? That is a debatable point. Do we need to conclude and involve our GPs more? Absolutely. Do our GPs need and deserve a new contract? Absolutely. But these are undeniable facts in terms of increasing access to GPs, but more importantly, access to chronic disease management. The kind of reforms I'm talking about, though, the kind of reforms all of us are talking about, won't happen overnight, but they can happen in a way in which, step by step, we improve services for our patients, provided, though, as a country, we stick at it. And I want to briefly reference the NTPF, because I think Susan's analogy is correct. It's absolutely my preference to invest the maximum amount of money into the maximum amount of effective places in the public health service to make sure we get historically high waiting lists down. Absolutely. But if I'm a patient at home tonight in urgent need of an operation in absolute agony, I make no apology for using any band-aid solution to make sure that person gets an operation as quickly and effectively as possible. And that's why we have reactivated the NTBF. I believe it was a mistake at a time of crisis in our health service to effectively deactivate it, and I do think it has a role to play. I want to make an important point. I don't believe frontline staff in our health service, from my many interactions with them, are fed up of reform. But what they're really fed up of is little bits of reform, piecemeal reform. They're fed up of Minister for Health X rocking up to the Department of Health and tinkering with the health system at the edges, closely followed by another new Minister for Health who has another idea, who wants to tinker with another little bit of the system. We need to stop running the Irish Health Service based on election cycles and based on individual ministerial ideology. And instead, we need to put in place, once and for all, a 10-year strategy with cross-party political and societal buy-in to build, develop, reform and modernise our healthcare service for the future. We need that overall plan that other speakers have talked about, because you don't just want my plan, you don't need my plan, you don't just deserve my plan, you need a plan that I will start to implement, but that will continue after me. Ministers for Health, we're mere mortal creatures. We move on. We need a plan that outlasts all of us. And if we're serious about it, and I'm really serious about it, we've got to do this. And we're in a Dáil, it's a very interesting place, in a minority government, and it's very diverse. But diversity need not be division. Surely, to God, we can pick enough political rows for the people in Dáil Éireann who need to win political arguments to point score to win elections, without deciding to pick on the poor health service. Surely to God, we can decide that we're going to park partisan politics and unify around a singular vision for the Irish Health Service. And that is the challenge. It's the challenge of the new committee. It's a challenge I'm absolutely up to. And let's get on and actually do that now. The theme, though, for the MacGill School this year is about moving on from the past to build the future. And for a while back there, if we're truthful with ourselves, and it's easy to forget as time moves on, but building the future wasn't a possibility, never mind a priority for much in this country, for the health service or indeed for any other service. We were all involved, all of us as citizens, in a fight for our own economic survival. We had to get the economy out of intensive care, to use a medical analogy, before we could simply do anything else. And we did it. And not this government, the last government, the next government. As a people, we did it. And let's reflect on this, though. Why did we do it? We didn't do it to satisfy Europe. We didn't do it to make our balance sheet look nicer. We didn't do it because we're all obsessed with GDP or we lie awake at night worried about bond yields. Why did we fight so hard to get to this point? And I believe, and I mentioned earlier, the rights of the citizen to an equal chance at a healthy life. I believe that's one of the reasons we did it. To rebuild the opportunity in this country again. To recreate the future that seemed our fate in the bleakest moments. Because we have a national instinct in this country that people should have an equal chance. And we have a very important national allergy to the notion that it's okay for some people to have no chance. And if I'm honest, as a practising politician and as a minister in this new government, I heard that loudly and clearly not so long ago on the doorsteps and in the ballot boxes. I heard from the people of Ireland, I heard from the people of Wicklow. That's great that the economy is back on track. Keep it going. We'd like to feel a bit more of it. But what are you doing with it? When are we going to see big issues like homelessness, housing, and in my case, the health service? When are we going to see that addressed? When are we going to see you give us the remedy to the national allergy of some people having no chance in relation to accessing the health services that they need? And Now, I think we have to actually say this is the time to change the focus. We've won the economic battle as a country. We need to keep it going, absolutely. We need to keep the eye on the tiller. I don't dispute that. But we now need to put that same degree of effort into concentrating on creating a better, fairer society for our people, a compassionate society, and one which looks after the people from the time we come into this world till the time we depart it. And central to this is building not a better health service, but a health service that is the best in the world. And that will only be achieved if we start every initiative with that simple but important question, is this really good for the patient? Ladies and gentlemen, that is the biggest single challenge facing all of us, because it will take all of us to get it right. I believe it's the single biggest and most positive challenge for this country for the next decade. It is one that requires energy. It is one that requires vision, hope, determination, and yes, that optimism I talk about. It's time we moved beyond labels like Angola and dysfunctional as terms for keeping the people of Ireland healthy and giving them great care when they fall ill. It's time we stopped looking at just the obstacles and concentrated on the direction. And maybe it's time we stopped assuming, to be realistic, it's absolutely necessary to be negative. It's not naive to aim high. In fact, I believe it's the only way to achieve anything worth achieving. And a world-class health service is so worth achieving. And I'm going to give this my absolute all to help facilitate the bringing about of this. Gyar míle agam.